All right, everyone's good. Okay. Good morning, everyone. Welcome to the people joining us via Zoom and those of you that are here with us in the Ether Dome. My name is Meridale Baggett. I'm one of the associate editors of the New England Journal of Medicine case records of the MGH, and I'm happy to welcome all of you guys to this morning's CPC. This is a very long and sort of beloved MGH tradition that we think is a tremendous teaching exercise, and we're excited to share this case with you guys today. Our primary discussant that will be teaching us today primarily is Dr. Gonzalez-Perez, who has agreed to discuss this case in the traditional unknown format, which means all that she knows about this patient is a approximately 2-page summary that I sent her about 6 weeks ago and said, good luck. And so she actually doesn't know the diagnosis here. And the reason that we do that is to have the benefit of getting to hear her thought process and how she would approach this patient in real time without the benefit of already knowing the diagnosis. So we can learn from her clinical reasoning and the way that she approaches patients. So I'm very excited to learn from you today. Thank you for accepting this challenge. She will be joined today by several folks. Dr. Buch from radiology will be going over the relevant imaging, and Dr. Seyedsadjadi will be talking with us about how the patient was managed and give us some follow-up on how he did over time. But at this point, I would like to introduce, one second, Dr. Okonkwo, who is going to tell us about this 80-year-old man with left foot drop. Dr. Okonkwo, if you can come up. Thanks very much.
So, 80-year-old man was evaluated in the clinic of this hospital for foot drop. So 5 years before this presentation, the patient noted that he needed to lift his left foot higher off the ground to prevent his toes of his left foot from dragging when he walked. Over the next 2 years, he noted progressive inability to dorsiflex the foot. And 3 years before this presentation, he began using ankle foot orthotic. 1 year before this presentation, he was evaluated in an neurology clinic affiliated with another hospital. At that time, he reported foot drop and occasional falls that he attributed to poor balance. On their examination, he reportedly showed wasting of the muscles below the left knee, weakness with attempt at left ankle dorsiflexion and inversion, loss of pinprick sensation of the mid shins bilaterally, and decreased vibration sense in the toes bilaterally. Blood levels of cobalamin, folate, thyrotropin, and hemoglobin A1C were normal, as were screening tests for syphilis and anti-nuclear antibodies. Serum protein electrophoresis was also normal, as well as serum paraneoplastic count, which showed autoantibodies. Testing of the blood for blood antibodies to sulfate-3 glucuronoparaglutazide, myelin-associated glycoprotein was. The blood level of creatine kinase was elevated at 456, and the level of aldolase was normal at 5.8. Imaging studies were obtained. MRI of the head was reportedly normal, and MRI of the lumbar spine showed multiple levels of diffuse disc bulging with facet hypertrophy, contributing to mild spinal canal stenosis. A needle electromyography of the left leg reportedly showed findings consistent with the moderate and severe subacute to chronic left L5 S1 radiculopathies. There were mixed amplitude units seen in the distal L5 S1 lacteals. The patient applied further intervention at that time. However, when his symptoms had not improved after 1 year, he presented to neurology clinic of this hospital for further evaluation. On evaluation of neurology clinic at this hospital, the patient reported a stable left foot drop. He also reported mild lower back pain without radiating symptoms and no bowel or bladder changes. There was no difficulty with breathing, chewing, swallowing, or double vision or changes in hearing at that time. The patient had a medical history notable for hypertension, dyslipidemia, the history of adenocarcinoma of the prostate treated with radiation 4 years before this presentation. Medications included aspirin, hydrochlorothiazide, lisinopril, laetropral, and simvastatin. He was married, resided in New England, and was retired from working insurance. He had smoked 1 pack of cigarettes for 30 years, but quit 30 years prior to his presentation. He drank 4 alcoholic drinks per day, and his family history is notable for a history of breast cancer in his sister, and a father who died at age 76 from esophageal cancer. On examination, he had a high step gait with foot slap of the left foot. He cannot walk on his left heel, but was able to walk on his toes and to tandem gait. On his cranial nerve exam, he had mild lower motor neuron facial weakness that was noted bilaterally, but more notable on the right, with asymmetric smile and overcomable eye floater and cheek puff. His motor exam was notable for wasting of the shoulder girdle, that was more notable on the right, and wasting of the calves. There was prominent scapular linkage that was also more notable on the right. His tone was mildly decreased throughout. There was no evidence of fasciculations, no evidence of action or depression myotonia or paramyotonia. Manual muscle tests under proximal distal muscles revealed MRC grain strength as depicted in the table, but in summary, there was subtle neck flexion weakness, symmetric weakness of shoulder abduction, symmetric weakness of hip flexion, and asymmetric toe extensor and ankle dorsiflexion weakness. That was worse on the left, and that was associated with weakness of ankle inversion, and plantar flexion that was restricted to the left leg. Deep tendon reflexes were 1+ in the uppers, trace of the brachioradialis, 2+ at the knees, and not elicited at the ankles. Plantar responses were flexor bilateral. MRI of the lumbar spine showed a large leftward eccentric disc herniation at L5S1, impingement upon the left greater than right exiting L5 nerve roots, and narrowing of the left subarticular zone and left lateral recess, encroaching upon the descendant left S1 nerve root. There was facet hypertrophy and ligamentous infolding, with multiple levels of mild central canal stenosis. Additional testing was performed and the diagnostic test was set.
Hi, good morning, everybody. I'm from neuroradiology, and I'm going to walk through the relevant imaging from the lumbar spine that was mentioned. So here we have a couple representative images. These are all obtained at the same time. They are T2 weighted sequences, so fluid in the spinal canal is bright. The first image on the far left is a mid-sagittal plane view of the lumbar spine. We see here that there's no significant curvature or abnormal convexity of the spine. The vertebral body heights look good, and we see the multiple levels of disc bulges at many levels here, contributing to mild spinal canal stenosis. There was no significant central spinal canal stenosis, high-grade spinal canal stenosis. This middle image here is a left paramedian image, and what we're trying to focus on here is we're looking down the column of the neural foramen. So what they should look like when they're not narrowed is this normal keyhole shape where we see this nice bright fat surrounding our exiting nerve roots. And you can see that when we get to the left neural foramen at the L5S1 level, we have lost our normal fat keyhole. We have this disc extending into the neural foramen here, severely narrowing the left neural foramen and pinching off our exiting left L5 nerve root. We had similar findings on the right side, but not as severe as the left side. The last column of images are the axial T2 sequences that are through the L5S1 level, just at two different levels. So we have this slightly cranial level here at the top. And you can see here we have this eccentric disc bulge that's kind of extending towards the left side. It extends into that left neural foramen, and it's encroaching upon our descending left S1 nerve root here. You can see that there's very little distance, and we're losing our CSF signal between the disc and this nerve root that's traveling down. If we go slightly inferior to this top image, still at the L5S1 level, you can see that that disc continues to encroach and actually touches the descending left S1 nerve root. We don't have that on the right side. You can see that this is pretty clear, but our left side S1 is being contacted. Great.
Hello, good morning. I'm happy to discuss with you my diagnostic approach to this patient. Let me show very quick. I thought it was the disclosures, but I don't have any disclosures for this talk. So we have an 80-year-old man with a 5-year history of progressive and painless left foot drop. And this is the patient's chief complaint. But the exam showed more generalized findings. So we have weakness of the facial muscles, periscapular muscles, hip flexor muscles, and also weakness of the distal right leg. The sensation is it is a little bit reduced distally in both legs, and the reflexes are hypoactive in upper extremities, normal at the knees, and absent at the ankles. So for me to call a syndrome that include the chief complaint plus the generalized findings, I'm going at this time to call it this syndrome left foot drop plus syndrome. So to try to explain this, I favor a generalized disorder, and in this case, I will favor to localize the problem in the peripheral nervous system. I cannot think of any central nervous system causing the exam findings, all the exam findings. However, the most common causes of foot drop are focal disorders, either in the central nervous system or more frequently in the peripheral nervous system. So, sorry, here, we are here. So in my talk, I'm going to go through why I don't think it is a focal disorder of the central nervous system or the peripheral nervous system, and why I think it is a generalized disorder of the peripheral nervous system, and which one. Okay, so in the focal disorder category, the first question will be to see if this is a central or peripheral nervous system. In the central nervous system, I always keep in mind two potential locations that can cause or mimic a foot drop. The first one is the corticospinal tract. So any disruption of the corticospinal tract from the medial homunculus in the primary motor cortex in the frontal lobe, all the way down to the gray matter in the ventral spinal cord can cause a foot drop. However, the exam in this patient didn't show any upper motor neuron sign. He doesn't have an increased tone. The reflexes were not brisk. The plantar responses were flexor bilaterally, and we even have a brain MRI that was normal. Also, the patient didn't report any neck pain. There are no sensory complaints, no sphincter dysfunction, and there is no mention of any sensory level. So the suspicion for myelopathy is very low. Another condition that I always keep in mind, because it happened to me in clinic twice, is a referral with a patient with foot drop that has a dystonia. I'm not saying that dystonia is a cause of foot drop, but I'm saying that can mimic very well a foot drop. And the key here is that the strength, the muscle bulk, and the deep tenor reflexes are normal in a dystonic foot drop. So sometimes as a neuromuscular doctor, when you see that the strength, muscle bulk, and deep tenor reflexes are normal, you probably start relaxing a little bit, but you shouldn't, because maybe it is a dystonic foot that has treatment and other type of management. So I always keep this in mind. So I cannot think on any other location in the central nervous system causing a foot drop, so I'm going to favor a peripheral nervous system disorder. And here, in terms of focal disorders of the peripheral nervous system that can cause foot drop, they are very common. At least we see very commonly this in our clinic. Any problem in the deep branch of the common peroneal nerve, or in the common peroneal nerve, or in the sciatic nerve, specifically in the sciatic nerve in the peroneal division that runs lateral to the tibial division, and then it is more prone to injury, or any problem in the lumbosacral plexus, or any problem in the L5 nerve root. All of these locations can cause weakness of the tibialis anterior muscle, that is the muscle that is in charge of the main muscle that is in charge of the ankle dorsiflexion. So I think we can quickly rule out the first two, because this patient has weakness of foot eversion, and this is the action of peroneus longus and brevis muscles, and these muscles are innervated by the superficial branch of the peroneal nerve. So a deep branch of the peroneal nerve does not entirely explain the foot drop in this patient. Then the patient has also a weakness of foot inversion, which is the action of the tibialis posterior muscle, and this is innervated by the tibial nerve. So then a common peroneal nerve problem does not entirely explain the foot drop either. And then we have sciatic nerve, lumbosacral plexus, and L5 nerve root. And I think the most important piece of information that we have from the history is that this patient doesn't have sensory symptoms and doesn't report any hip, thigh, or radicular pain. And this lowered very much for me the possibility of a sciatic neuropathy, lumbosacral plexopathy, or L5 radiculopathy. It is possible to have a painless lumbosacral plexopathy that we see induced by radiation, and this patient received radiation, but he received radiation only for the prostate, and the radiation was given 1 year after symptom onset. So this wouldn't be the culprit of this foot drop in this patient. And then there are other pieces of information in the exam that do not rule out this condition, but lower even a little bit more my suspicion for it. So he has a strong, he has a strong knee flexors that this makes a little bit less likely these three possibilities, and a strong hip abductors that in theory makes less likely a lumbosacral plexopathy and an L5 radiculopathy, although as I said, that does not rule it out. And then we have the MRI. This patient had 2 MRIs. I think it would be important to know if there is progression. I think the MRIs were done time apart. So I think it would be important to know if there is radiological progression of the radiological findings that that we just mentioned. Because if the radiological findings are stable and the patient continues to get worse from the foot drop, that would then even lower more my suspicion for an L5 radiculopathy. And another thing is like there is impinging of the left L5 and encroaching of the left S1. Look to me that the S1 is more compromised than in the L5, but this patient has more weakness in L5 muscles than S1 muscles. So there is a little bit of clinical radiological dissociation. And then the EMG was reported as left L5 and S1 radiculopathy. I'm going to come back to the EMG in a bit. I just want to say that even if electrically we have evidence of a left L5 S1 radiculopathy, because of all the characteristics that I discussed before, I'm not going to conclude that this electrical L5 is the cause of the foot drop entirely. Okay, so now I move to the possibility of a generalized disorder of the peripheral nervous system that can count for this foot drop plus syndrome. And here, the next question that I try to answer is, which is the pattern of muscle weakness distribution in this patient? And this is sometimes difficult to identify, but I usually focus on the muscles that are the weakest. I know that he has muscle weakness in different muscle groups, but the weakest muscles for him are the periscapular muscles with this asymmetric scapular winging, and also this weakness in the anterior compartment of the left leg. And this is a pattern that we call scapuloperoneal muscle weakness distribution. And then I think on generalized disorders of the nerve, neuromuscular junction, or muscle that can cause this scapuloperoneal muscle weakness distribution. So in terms of nerve, we always, in terms of generalized disorders of the nerve, we always think in motor neuron diseases or anterior horn diseases, such as, for example, ALS. ALS is the most common motor neuron disease that we see in adults. But a scapuloperoneal distribution of the muscle weakness will be very atypical. For me, it will be very atypical that a patient has very strong distal muscles in the upper extremities and very weak distal proximal muscles in the upper extremity. Usually it's the other way around. By the time that the patient with ALS has weakness proximally, they have more weakness distally. So that will be very unlikely. But there are other anterior horn diseases, such as very rare forms of spinal muscular atrophy that can be associated with this distribution of muscle weakness, the scapuloperoneal distribution. And and some neuropathies, specifically inherited neuropathies, Charcot-Marie-Tooth forms, that also can be associated with the scapuloperoneal weakness. But I think this is very unlikely because usually these patients present much younger than our patient. And also the weakness is more symmetric or slightly asymmetric, but not so asymmetric as in this patient that we are presenting here today. And also I would expect other clinical features in this condition. For example, in rare spinal muscular atrophy, usually there are other features such as congenital absence of muscles or buccal palsy, scoliosis, or arthrogryposis. In some forms of CMT, we see high arches and hammer toes and maybe sensory involvement. So I think this will be very unlikely in our patients. So in terms of neuromuscular junction, myasthenia gravis, or Lambert-Eaton myasthenic syndrome, I think this distribution of muscle weakness will be also very atypical. Definitely, these patients may present with distal weakness, but with a scapuloperoneal muscle weakness distribution, I think it will be atypical. In addition, this patient doesn't have fluctuating symptoms. The fatigue is not a main symptom, and there are no ocular symptoms, as I would suspect it happening in myasthenia. or in most of the patients with myasthenia, and there is no fatigability on exam, or there is no mention of that. So I'm going to favor that he has a myopathy, a muscle problem, and here I'm going to go back a little bit to the EMG, because I know that the EMG show a neurogenic pattern, but because the history and exam and this reasoning points me to a muscle problem, I have in my mind like three possible scenarios. First, that the absence of a myopathic pattern on EMG doesn't rule out myopathy, and this is something I think important to always consider. The other thing is like could be that there is a superimposed L5 radiculopathy that is not the culprit of the foot drop, and then on the EMG we see when the patient contracts the muscle, we see these large motor unit potentials that may mask the presence of other small motor unit potentials that are typical for muscle problems. Or also there are long-standing myopathies that on the EMG has a pseudo-neurogenic pattern. So I think any of these possibilities is possible and in this patient, and I'm going to stick with my suspicion that this is a muscle problem. Sometimes at bedside, one thing that, or one bedside test that it's very helpful if it is present. If it is not present, it's not helpful, but if it is present, it's very helpful. For example, in a patient with ankle dorsiflexion, weakness means that the tibialis anterior muscle is weak. So, so then I usually look for the muscle bulk of the EDB muscle. So in a nerve problem, because both muscles, right, are innervated by the same nerve, by the deep branch of the peroneal nerve. So in a nerve problem, if the tibialis anterior muscle is weak, the EDB, that is more distal, it should be atrophic and very weak too. But if you see that the tibialis anterior is weak and you see a very good EDB bulk, that points more to a muscle problem. And when we see this, we almost have it. We don't have that information, but I still think could be a muscle problem. And here I'm in the next two slides, I'm going to present the pattern of muscle weakness that we see in myopathies. The first one is the limb-girdle pattern of muscle weakness. So this proximal and relatively symmetric weakness in upper extremities and lower extremities. This is the most frequent pattern that we see in hereditary and acquired myopathy, but it is also the least specific. So it doesn't help us very much at bedside. Then we have the distal pattern, patients with, once we know it is a muscle problem, patients with weakness in distal upper and lower extremities. And the classic example is myotonic dystrophy type 1, which is the most common muscular dystrophy in adults. And then we have this pattern that is distal weakness in upper extremities and weakness of the proximal lower extremities. And this is something that we see in inclusion body myositis, which is the most common myopathy that we see over the age of 50. And then we have the pattern that I'm suspecting here, the scapuloperoneum distribution of muscle weakness. And here we have muscular dystrophies, myofibrillar myopathies, congenital myopathies, and very important to keep in mind Pompe disease because it has treatment. However, in this patient, the weakness is very asymmetric, and asymmetric weakness can be seen in muscular dystrophy, but very, very asymmetric weakness is something that brought me to consider FSHD, facioscapulohumeral muscular dystrophy, because in this muscular dystrophy, the weakness can be very, very asymmetric. And then also he has facial weakness that also goes with this diagnosis. He doesn't have, I think on the exam, elbow flexors and elbow extensors were strong. So he doesn't have this humeral component of the FSHD. But I think everything else, I think, fits quite well. So I think even if he doesn't have these humeral components, I'm going to favor an FSHD diagnosis. These are other patterns of myopathies, sometimes ocular myopathies, ptosis or ophthalmoparesis. These patients very unlikely see double because the weakness in the eyes is very well aligned. So even if there is ophthalmoparesis, they rarely complain of diplopia, unlike in myasthenia. And then another pattern is this weakness in eye muscles, but also weakness in swallowing muscles and hip flexor muscles. And this is very typical in oculopharyngeal muscular dystrophy, or maybe weakness only in the neck extensor muscles. So this pattern of weakness prompts us to consider very specific differential diagnosis and help us at bedside to guide the further testing. So I think this patient may have FSHD. There are two types, type 1 and type 2. Type 1 is more frequent than type 2. We cannot distinguish one from the other in terms of phenotype. They are identical, but they have different genetics that I will explain in a bit. And they are autosomal dominant diseases. This is the third most common muscular dystrophy overall after Duchenne muscular dystrophy and myotonic dystrophy type 1, and the second most common in adults. And in addition to the asymmetry of the muscle weakness distribution, which is very prominent, there are other two important characteristics. And it is that the progression of the muscle weakness follows a descending pattern. So the patient, the weakness starts usually in the face, but this facial weakness goes unnoticed. It's very unlikely that the patient comes to the clinic complaining of facial weakness. Then the weakness progresses to the periscapular muscles and proximal upper extremities. And actually, this is the most common initial symptom in FSHD. Patients who come to the clinic complaining of unable to lift objects above the shoulder level. And then the weakness progresses to the abdominal muscles and the hip flexor muscles, and then progresses to the anterior compartment of the lower leg. So I think this is what may have happened in this patient. Maybe this patient had weakness all his life in the face and in the periscapular muscles, but maybe it went unnoticed, or maybe he compensated very well for it and he didn't seek medical attention. And then when he developed weakness of the leg and he started falling is when he went to the doctor. But then we have the question, why so rapid progression, right? 5-year history of so rapid progression in this patient with FSHD. Usually FSHD is a quite a stable muscular dystrophy and patients remain quite stable for years. But in this specific muscular dystrophy, and I don't think it is known why, we see patients with rapid deterioration, periods of rapid deterioration of specific muscle groups that can last for years. And I think this may be what is happening in this patient. He presented with this first period of rapid deterioration of these muscles in the anterior compartment of the left leg, and this was the debut of the FSHD for him. The CK can be normal or a little bit elevated, as it is in his case, and the EMG is non-specific. So the EMG help here to differentiate muscle from nerve, and for the reasons I explained before, sometimes it's difficult even with the EMG to differentiate muscle from nerve, and history and exam is what should guide your suspicion. I will ask this patient questions to see if I can uncover some symptoms, maybe not symptoms because he didn't report it, but maybe some weakness that he has had during his life. So I will ask, are you able to whistle, drink through a straw? Do you sleep with eyes semi-open? Do you have difficulties lifting objects over the horizontal? How do you do in sports? Maybe he didn't play in sport and we cannot tell, and he compensated for that. Or were you able to do abdominal crunches? Do you have hearing loss? And I think they mentioned that this patient didn't have hearing loss. This is very important because sometimes this is associated with muscular dystrophies, and FSHD is one of them. Also retinopathy. Usually this happens in younger FSHD patients, but we call it Coats disease. It's a retinopathy, and we have to make sure that the patient has good vision. And I will ask about possible family members who have maybe similar symptoms as him. And then I will look for signs, additional signs or findings on the exam. So patients with FSHD have this in the first figure, these trapezius humps that you can see here on the left. Also, the clavicles are straight, the shoulders are leaning forward, and that's why the clavicles are straight. And also these horizontal axillary folds, that is a manifestation of pectoralis muscle atrophy or weakness, very typical in FSHD. Here we see the scapular ganglion this patient have, and also here in C and D, you can see, how high can go with the arm, the left arm in C, and then the doctor is helping to fixate the scapula, and now ask the patient to go up. And then when the scapula is fixated, then the arm goes higher. And this is important, could be a bedside predictor of how, what is going to be the function of the arm elevation if we surgically fix the scapula. Some of these patients go for a surgical fixation of the scapula. And another sign that is not entirely specific of FSHD, but we see that sign very often in FSHD patients, is the Vibor sign. So the Vibor sign, the patient is supine. It is a sign that tells us that the patient has weakness in the abdominal muscles. So we have the patient in a supine position, we look the umbilicus, and then we ask the patient to try to do, indeed, you can see that they are asking the patient to try to do an abdominal crunch or just a flexion of the trunk. And then you see that the umbilicus goes up. And this is because the patient has weakness of the lower abdominal muscles, so the upper abdominal muscles are pulling the umbilicus up. Sometimes we see the opposite, the inverted Vibor sign is the opposite. It's basically the umbilicus go down because the upper abdominal muscles are weaker than the lower abdominal muscles. Okay. So I favor FSHD type 1 based on frequency, or maybe if not type 2. I cannot explain with this diagnosis why he has diminished sensation in lower extremities, but this is asymptomatic, so maybe it's an asymptomatic, length-dependent, symmetric sensory polyneuropathy, possibly idiopathic. I don't think it's clinically relevant, but I see that his alcohol intake is increased, so maybe that has to do something with it. And I think it's important to understand the genetics of FSHD because it's not uncommon to have false negative or false positive when we send this genetic testing to maybe labs that don't do the entire study. And I'm going to try to explain here the genetics. I think it's quite complex, so I hope I can explain it well. So we are in the long arm of chromosome 4. And I'm going to explain first the top situation, which is the normal situation. We have one copy from mom and the other copy from dad. And the normal situation is that this is a region of the genome in which we have more than 10 repeats of these macrosatellites before C4. So more than 10 in one allele, more than 10 in the other allele. So this region of the genome is hypermethylated, which means that the DNA is inactivated, so shouldn't be transcribed. So we don't have DUX4 transcription, which is good. So important also to know that in this region, we have some sequence of nucleotides that are very important. And depending what is the sequence, we are going to call the allele A or B. So a person can be AA or AB or BB. And in a normal situation, it doesn't matter because this region is highly methylated, is inactivated. What happened in FSHD type 1? In FSHD type 1, there is a contraction of one of the alleles, okay? But this is not enough to cause the disease. The contraction makes this residual DNA hypomethylated. But for this hypomethylated DNA be transcribed, the contraction has to happen in the A allele, which is the permissive allele. So, for example, if we send a sample for FSHD, we see the contraction, but it is in a B allele, this doesn't cause FSHD. And this is a potential cause of a false positive result. Okay, I just want to mention that currently therapies are targeting this toxic DUX4, and hopefully they work in the future for these patients. And what happened in FSHD type 2? Actually, the mutation in FSHD type 2 is far away in chromosome 18 in another gene, SMCHD1, and mutations in this gene cause hypomethylation in different regions of the genome. Including this chromosome 4. So when the patient in chromosome 4 has an A allele and this region is hypomethylated, also we have transcription of DUX4. And then the patient has FSHD type 2. So What I will do in this patient is to send genetic testing for FSHD type 1. If it is negative, I will test for FSHD type 2. In parallel, and because I don't want to miss an L5 radiculopathy, I will probably do an EMG. Because I'm going to do it anyway, I will probably do the nerve conduction study to see, curious to see if the response that I get when I report from the EDB muscle is higher than when I report from the tibialis anterior muscle. And this is also will correlate with my, with this bedside test that we do sometimes to differentiate muscle from nerve. The polyneuropathy, he is 80. It wouldn't be uncommon to find sensory nerve in the legs, but that's okay. So I'm not suspecting any demyelinating problem, but we can check if it is axonal or maybe there is no neuropathy at all, and that would be great. And then in the needle EMG, I will put the needle in muscles that are not affected by FSHD and that are L5 muscles to see if maybe the L5 nerve root is giving some problem or have some support of it. So, and for that, for example, the gluteus medius, I think it's a good muscle, not affected in FSHD, and it's an L5 muscle. And then I think it's very important to try to obtain the first MRI and compare. So, because maybe there is no radiological progression, and then I would then even send the patient to neurosurgery or spine neurosurgery. But if I see that there is progression between MRIs, I definitely will discuss it with spine surgery. And that's all. Thank you. Yeah.
Thank you so much, Dr. Gonzalez-Perez, and for running two different computers and advancing slides on two different monitors at the same time, and still delivering a really beautiful discussion. Dr. Seyedsadjadi, can you please come up and tell us about the diagnostic testing in this patient?
Thank you so much for the lovely presentation and great discussion. All right. So nerve conduction studies as part of electrodiagnostic solution is often requested for evaluation of more common causes of foot drop, which is usually either a common perennial neuropathy, as Dr. Gonzalez mentioned, versus L5 radiculopathy. However, nerve conduction studies can also give us some clues with regards to other processes, neurogenic or myopathic, that could also mimic foot drop in similar context. So this study was notable. It's a repeat study. It was not the original study which was reported. Showed relatively preserved sensory responses and asymmetrically lower left perennial motor response reported over tibialis anterior, and relatively symmetrical perennial motor responses reporting from extensive digital and brevis muscle. As Dr. Gonzalez mentioned, this leads to either two major differentials. One, electrodiagnostically, this could still be seen in the context of a preganglionic neurogenic process, such as an L5 radiculopathy, where EPB could be less effective, disproportionately less effective compared to tibialis anterior, or a primarily a myopathic process. This can occasionally be seen also in the context of neuromuscular junction dysfunction, like in myasthenia gravis, and or an acute to subacute perennial neuropathy where the degeneration is not yet occurred. So needle electromyography complements the electrodiagnostic nerve conduction portion of the study with helping with one, characterizing or better localizing, firstly differentiating between a neurogenic versus a myopathic process. So typically, in a neurogenic process, there are increased number of muscle fibers that are innervated by a single motor nerve. And that leads to large motor unit action potentials, rapid firing rapidly, as you see in the top panel, from a patient with a known L5 radiculopathy. However, in this patient, as you can see, the action reporting from this patient's tibialis anterior muscle, showing small duration and early recruitment of small and brief and polyphasic motor unit action potentials due to diminished number of functional muscle fibers that are firing in association with individual motor nerves. So with the clinical history and electrodiagnostic finding, as Dr. Gonzalez rightly concluded, we pursued targeted testing for FSHD, and this patient was found to have short D4Z4 repeat in the first FSHD allele, consistent with diagnosis of facioscapular osteodystrophy. As it was nicely elaborated again by Dr. Gonzalez, this condition is caused by de-repression of DOX4 gene, which is normally presents in embryologic phase, and it gets repressed in most adult tissues except for, I believe, thymus and testes, and it's the product, which is DOX4, is toxic to the function of the muscle, different pathways. So this usually hypomethylated by D4Z4 heterochromatin repeats, and if D4Z4 is short, either directly or indirectly affected by SMCHD mutation, it can cause expression of DOX4, cause distinct myopathy. So the diagnosis was facioscapular muscular dystrophy type 1. So again, Dr. Gonzalez had a nice slide showing the descending pattern of weakness. Usually patients have facial weakness. Occasionally they may have exotomous looking face. This is mostly due to incomplete eye closure, difficulty listening, and as disease progresses, patients will have scapular winging, and which is usually more prominent when patients are abducting and overflexing their upper extremity. Over time, they develop lower extremity weakness. Tibialis anterior weakness can also happen occasionally earlier on. Asymmetry, similar to the stage that our case, is a common feature. Occasionally, patients have minimal contracture, flattening or horizontal clavicles, and folding of axillary folding and sloping of shoulders are common clinical features. So there's a linear relationship between the age at diagnosis and the size of the D4Z4 deletion. And the men usually present a little bit younger than women, and infantile onset also can occur. It's usually with more severe sort of small repeats. And penetrance is variable at age 50. This number is changing. And I believe that roughly about a third of patients don't report positive family history, raising possibility whether the phenotype is milder or is a de novo mutation. So the management is predominantly at the moment symptomatic. Aerobic training with low weight has been shown to be beneficial in some patients with FSHD. And then management of symptoms, mainly ground reaction, ankle foot orthotics would be considered, specifically in these patients who also have an element of reflection weakness. This can help them not only with foot drop, but also with, helping them with knee buckling symptoms. Scapular fixation, again, as mentioned earlier, could be helpful in some patients, not always. It's usually kept for people who have otherwise strong deltoid and minimally affected and on the dominant side of the patient. And then other symptoms that, again, I was nicely mentioned in earlier presentation, screening for hearing loss is very important. Use of eye lubricants and even ophthalmic surgeries would be considered for the management of dry eyes. Patients should have routine eye examination and fluorescein angiography. for early detection of vasculopathy, which can be treated with laser coagulation and stop from evolution of fulminant Coats disease and blindness. And obviously, respiratory measures bypass some patients who have restricted lung control. So I found two exams. One of the exams could have been prior to his first initial presentation in 2013, where a patient had 4 out of 5 ankle dorsiflexion on the MRC scale. And more recent examination, which was very similar to the exam that we saw initially. Symptoms have progressed, and patient is weaker, both proximally and distally, with symptoms seem to have been managed well by measures, mainly ankle foot orthotics, and subtle adjustments in to help him with physical therapy and exercise. So, and that's it. Great.
Thank you. Thanks very much. So thank you very much to all of our discussants. We have a few minutes for questions. If we have any questions from the Zoom world that is joining us, or questions here in the Ether Dome. Carol, how will I see the questions on here? Should I stop? I'll stop share and then see if there are any questions in the chat. Questions? Okay. Any questions from anyone in the audience here? All right. Oh, yes.
And Louisa, Reza, thank you for that nice presentation. I'm just curious, what's the current status of what are most people doing with regards to genetic testing? And does this have implications for prenatal? I mean, most of these FSA patients do pretty well, but it's not a trivial diagnosis. You update?
So the question was related to whether or not there's any movement towards genetic testing, and if there are any implications in different patients from a prenatal perspective. So Dr. Seyedsadjadi, and then Dr. Paloma, if you would also like to.
Thank you. That's a great question. I think it's mostly case dependent.
Yeah, this is where. Yeah.
So it depends on the case and clinical scenario when we decide whether we should do individual testing. The testing for FSH type 1 specifically is a different type of testing that is not part of regular sequencing, which would make it a little bit more difficult to offer it easily as compared to other testing. So I think that's an important question. Typically, there are variable practices in this. Typically, I would consider this in patients who are younger and they are considering having family and they are interested to pursue this option in terms of testing, but not as a prenatal screening. Otherwise, I don't typically consider it.
Dr. Gonzalez-Perez, do you have additional thoughts on that?
Yeah, so I agree. And this is not a muscular dystrophy that typically affects heart, which is one of the, I always keep in mind, is this muscle problem affecting the heart, yes or no? If it is yes, I'm a little bit more pushy maybe to go for genetic testing, even if the, obviously, you know, with genetic counseling and all this. But it doesn't affect the heart, but there are reports of FSHD with some heart problems, but it's not, doesn't typically affect the heart. So then I usually don't recommend testing children, but this is based on a case, you know, depends on the patient, the family, obviously, yeah.
A great question.
Mm-hmm. Any other questions from the audience before we adjourn? Okay, not seeing anything in the chat. Okay, wonderful. Good luck with the rain today, everyone. Thanks again to all of our discussants. Thank you. Thank you.